Welcome everyone for my channel. I hope you can enjoy my rheumatology practice. I will try to mention the main and the most practical points in the rheumatoid arthritis. Most of the rheumatological diseases have no diagnostic test or criteria to diagnose or to confirm the disease. So we have most of our rheumatological diseases have multi-system symptoms and signs and complications. Therefore, with my videos, I hope I could help you to classify the rheumatoid diseases early and to put a good strategy for treatment and follow-up to prevent causes and comorbidities. Now, we'll start the rheumatoid arthritis. It is a rheumatological disease very common. It is usually started with constitutional symptoms or a cold flu-like symptoms like fatigue, fever with mild degree, myalgia, then the musculoskeletal symptoms and extraskeletal symptoms. The extraskeletal symptoms like the red eye, the episcleritis, which may develop to corneal perforation and blindness. There is a recurrent chest infection and the lung nodules that known as Kaplan's disease in the co-workers, which may develop to pneumonia and interstitial lung disease. The interstitial lung disease is very common in rheumatoid arthritis patients due to the infection and the drugs. The heart could be affected in all layers, so the rheumatoid nodules have problems in the myocarditis and epicarditis and endocarditis, sometimes with cirrhosis. The conditions can make a conduction block or a valve disease. Also, the vessels can be sclerotic with hypertension manifestations. The skin, usually we can see the rheumatoid nodules in the uncontrolled patients, or the vasculitis with palpable purpura and Raynaud's in the chronic uncontrolled disease. The CNS, mostly there is a peripheral neuropathy the patient is complaining from. Other associated clinical findings, very common, is autoimmune thyroiditis, which is very common, not related to the disease itself, but it could be present as a disturbance in the immunological of the patient. There is Felty syndrome, a triad with arthritis, splenomegaly, and low white blood cells. So it is important to control the patient and to follow the CPC and white blood cells. The lymphadenopathy is very common, and it has many causes. Maybe due to the low immunity and infection, or Felty syndrome, or malignancy, or Jordan disease. The extra-articular manifestation usually very common and maybe not appear in the first visit, but the main complaint for the rheumatoid arthritis is the musculoskeletal manifestations. The main joints are the hand and foot. The hand, mostly the wrist, the metacarpophalangeal joint, the PIP joints, in the foot the subtalar joint and the metatarsophalangeal joint. Usually the joint is swelling, hotness, redness, loss of function, with morning stiffness more than 1 hour, with bilateral symmetrical in distribution. The small joints are the most affected, with the deformities which appear in the late phase after bone destruction, and the large joints can also be affected. The temporomandibular joint in the face could be affected. The cervical spine is very important. It is a synovial joint. It has a atlantoaxial joint, and neck pain and stiffness with complications by subluxation and may cause death. Avoid making neck extension for the rheumatoid disease patient. Synovitis and synovial hypertrophy is the main complaint in the joint, and the main problem in this joint is the synovial hypertrophy, which make damage for the structures beyond it. And ganglion cyst, decurvant Baker cyst, is very common. Any tendons can be affected and inflamed, and the inflammation make it more weak, and it may be end with tear. Muscle wasting due to pain and disuse, atrophy with weakness and gathering. It is very important to maintain the hand function in the rheumatoid disease patient, but as a complication, it may lose the hand grip and the fine movement of the hand. The drugs and the disuse may cause osteopenia, osteoporosis, and the damage of the cartilage make the deformity unchangeable or irreversible. To conclude all these signs and symptoms in the rheumatological disease, in the RA, we do as classification criteria. For RA, the ACR 2010 is the most used classification criteria to classify the rheumatoid patient and not to diagnose, but it is very important to classify the patient as early as possible to give him the appropriate treatment. These criteria include 10 points for the joint involvement, tenderness or swelling, the serology, rheumatoid factor or ACPA, the anti-CCP is more specific ACPA type, the acute phase reactant ESR and CRP, the duration of symptoms, if it is more than or equal to 6 weeks or less. The patient who got more than or equal 6 points is definite RA. However, we could suspect RA patient with less score if you are expert rheumatologist enough. Okay, let's see what the comorbidities could occur for our RA patients. The musculoskeletal system include the joint deformity and loss of function, the muscle weakness and wasting, the cervical subluxation and dislocation, the tenosynovitis and tear, the eye perforation, the lung, interstitial lung disease and fibrosis, the atherosclerosis, the ischemic heart disease, heart block, Felty syndrome, associated conditions like thyroiditis, infection, Sjogren. The chronic disease may develop to vasculitis and amyloidosis. Even the patient who got treatment may develop drug toxicity or comorbidities like bone marrow suppression, anemia, osteoporosis, gastric ulcer, gastritis, liver toxicity. And therefore, we advise a patient for regular follow-up for the disease activity, which can count the number of joints pain or tenderness, for the pain degree, for the inflammatory markers, and the most common used is the DAS28 score. Also, the CDI is a good activity disease score can use in the clinics. He don't need any lab. The importance of the disease activity scores is to manage the patient who is aggressive with aggressive treatment, for the follow-up to unresponsiveness to the treatment, to determine the drug effect, and if we could insert another drug or change it or adding biologics, if we could decrease the doses if the patient is improving. The hand and feet x-ray can show the damage of the joints, and we can do it for diagnosis at early and for follow-up after 1 or 2 years to maintain the treatment and to know the case and how it is going on. Is it a progressive, regressive disease for biologics early, or the statement is controlled and no need for change the drug. eye slit lamp, and ophthalmological evaluation for now and then, screening for infections. The laboratory is the acute phase reactant like ESR, the liver function, the renal function test, the CBC, the lipid profile. Due to many drugs, it may affect the liver and renal, and white blood cells should be controlled, and anemia. The RA is very common to cause all types of anemia. Echo, chest x-ray, pelvic abdominal ultrasound, thyroid function, and thank you.